So hi, everybody. Welcome. My name is Sally Safi. I'm Director of Graduate Studies, and I'll be facilitating this session today, which is a super exciting session. One of the most exciting times of the year at PFRH is when we have our second year MSPH students present their master's essays. Today, we have 3 students who completed the bachelor's MSPH program. So they are all graduates of Johns Hopkins University undergrad and came here to do the MSPH program in population, family, and reproductive health. And they are finishing a little bit early in term 3. And so they have done an incredible job of getting their essays finished a little bit ahead of time. And so I first am going to welcome, sorry, I lost my intros. I'm first going to welcome Maclaine Barre-Quick. She is in the women's sexual and reproductive health area of interest, and her essay is on the global burden of stigma and discrimination against transgender and gender diverse adults. So Maclaine, I'll pass it over to you.
Thank you so much. Good afternoon, everyone. Today, I will be presenting findings from a systematic review and meta-analysis on the global burden of stigma and discrimination against trans and gender diverse adults. This study provides a synthesis of the existing literature on the prevalence of stigma and discrimination globally and highlights key areas where policy changes, interventions, and social support are needed. And before I start, I just want to give a quick shout out to my reader, Emmy Hughes, and to my wonderful co-authors who are also here today. Stigma and discrimination are significant contributors to inequities faced by trans and gender diverse individuals worldwide. These barriers affect access to healthcare, employment, housing, and legal protections, increasing the risk of poverty, unemployment, and homelessness. In addition to institutional discrimination, trans and gender diverse individuals often experience stigma in interpersonal relationships, including rejection from family and friends. Despite growing awareness around these issues, systemic barriers persist, reinforcing social and health disparities. This study in particular aimed to synthesize existing global evidence on the prevalence of stigma and discrimination against trans and gender diverse adults. For our methods, we conducted a systematic review and meta-analysis following PRISMA guidelines. We searched PubMed, Embase, CINAHL, Cochrane, Lilacs, and PsycInfo, as well as the gray literature. Articles were included if they presented quantitative data on stigma and discrimination, and if the participants were aged 18 plus, or if the authors disaggregated data for those only 18 plus, identifying as trans or gender diverse. We conducted a meta-analysis using the metaprop function of the meta package in R. For studies that presented scale analysis, if standardized cut points were available, we used those. However, if they were not, we classified scores as low if it was 0 to 1/3 of the maximum possible score, moderate if it was 1/3 to 2/3, and high if it was 2/3 to the maximum possible score. To structure our analysis, we categorized stigma and discrimination into 6 domains based on the STRIVE model, which was originally designed for HIV stigma, and includes anticipated stigma, internalized stigma, perceived stigma, experienced stigma outside of legal and institutional environments, and discrimination within legal and institutional environments, as well as resilience as a coping strategy. In total, we included 98 articles representing 94,592 participants from 26 countries. Most of this data, as you can see, came from high-income countries, in particular the United States, while low and middle-income countries were relatively underrepresented. Anticipated stigma refers to fear of discrimination, sometimes leading individuals to avoid certain spaces or services. So in 2 studies from South Korea and the US respectively, 47% and 61.8% of participants reported avoiding using public restrooms due to a fear of harassment. Similarly, in an article from the United States, 26.1% reported fear of seeking police assistance. And 1/4 of participants in a study from Cambodia feared arrest due to their gender identity. Other articles also reported fear of accessing healthcare services and fear of being publicly ridiculed. Internalized stigma occurs when individuals absorb negative societal beliefs, leading to self-directed negativity. For this outcome across 3 articles, prevalence ranged from 16% to 56%, with higher levels reported in the 2 studies from Argentina and Mexico than the study from the United States. Other studies use scales to report this. Many studies use the Gender Minority Stress and Resilience Scale and found moderate levels of internalized transphobia, the definition of which closely aligned with our definition of internalized stigma. Perceived stigma reflects how trans individuals believe society views them. Multiple studies used the Everyday Discrimination Scale, which ranges from 0 to 44, and found scores between 12.7 and 19.9, indicating moderate levels of perceived stigma. Additional scales reported moderate to high perceived stigma levels in Canada, Brazil, China, Turkey, and the United States. Experienced stigma from family and friends was also common and concerning. 35% of transgender women in a study from 8 African countries reported experiencing disparaging remarks from family members, and 29.8% of that same sample felt rejected by friends. 51.6% of participants in an article from Brazil experienced derogatory language from family members, and similar or even higher rates were found in China, the US, the Dominican Republic, and Mexico, highlighting family rejection as a major challenge. We were able to conduct meta-analyses on a subset of 40 articles total across these categories that provided comparable measures for the following categories. In housing discrimination, pooled prevalence of 17.8% was found for reporting being denied housing or being evicted. Similarly, healthcare discrimination, 25%, experiencing mistreatment or denial of care. Employment discrimination, 33.9% for facing workplace discrimination. And for police discrimination and discrimination within the prison system, 38.3% reported harassment or abuse. And as a subset of employment discrimination, specifically being denied a job or a promotion or losing a job due to your gender identity, we found a pooled prevalence of 30.5%. Resilience was also found at high levels despite the high levels of stigma and discrimination. So for example, in a study from Jamaica, resilience scores averaged 19.9 on a range from 6 to 30, indicating moderate bordering on high resilience. And in Turkey, similarly, trans individuals had high resilience in the study with a mean score of 128.62 on a 165-point scale. Other studies also reported moderate to high resilience. Some of the key limitations of this study that should be considered are that there are geographical and income-based gaps. So most studies originated in high-income countries, particularly in the United States, limiting global representativeness both by geographical region and by country-level World Bank economic classification of income level. Additionally, many of these studies relied on subjective experiences and self-reported data, which may introduce bias. There was also heterogeneity in measurement and definitions of stigma and discrimination across studies, which complicated direct comparisons in some cases. And finally, there is sampling bias, as many of these studies used convenience samples, which sometimes is necessary, but may not necessarily reflect the broader trans and gender diverse population. In conclusion, this review highlights the global burden of stigma and discrimination against trans and gender diverse adults, emphasizing the need for structural and policy changes to improve health and social outcomes. So what might that look like? Some recommendations for policy and practice would be, first and foremost, stronger legal protections against discrimination in employment, healthcare, and housing, as well as training for healthcare workers to implement affirming care, both in the provision of gender affirming care and also in the provision of healthcare more generally, and economic support programs, developing job training and employment programs for trans individuals, since it seems that that barrier to job entry and job promotion is so much higher. And finally, community advocacy, increasing education efforts to reduce societal stigma around the globe. And for future research, expanding to low and middle income regions, expanding into geographically underrepresented regions, as you can see here, parts of Africa, Europe, and others, and a use of more rigorous sampling methods, which can be difficult, especially with these populations, as it's hard to create a true frame. But where that's possible, it would add weight to the existing literature. Thank you so much for your time and attention. I'm happy to answer any questions.
Excellent job, Maclaine. Thanks so much. We have a couple of minutes for questions. What questions do people have?
Hello, I have a question.
Yes, Anna.
Um, so when you looked at resiliency, I'm curious to know if you sort of noticed or identified any factors associated with resiliency, like was it high connection with community or whatever factors might kind of explain or might be looked into in the future contributing to that high resiliency that you guys found?
Yeah, so that correlation wasn't really part of our review. So we were looking within this structure, sort of all of these kinds of stigma, really just looking at prevalence as opposed to looking at different factors that were related to resilience. We just found that there was high resilience within these populations.
Cool, thank you.
Yeah. Please.
So great job, Maclaine. Particularly timely work given all that we're hearing. I was wondering if you could share a little bit about your thoughts for dissemination, because I would think that many organizations would be really keen to see the synthesis that you wonderfully did.
Yes, so I've been working with Teresa and Caitlin, who you can see their lovely faces here. And I think Erin is here somewhere as well. This is actually done as part of kind of a set of reviews to inform WHO guidelines eventually. So we're working towards publication for that.
Can't wait. We will help you disseminate.
I'll ask. I think we have a lot of first year students here in the MSPH program, and just thinking ahead about master's essays. And you reviewed a lot of articles. It was quite a large undertaking. Could
Yeah.
you talk a little bit just about like what the process was like and how it went?
Yes, and I was not alone. I was working with a team, so that definitely helps a lot. Um, I would say that's the biggest thing is just if you're working with a team, that's super helpful, but also just being super organized and systematic about the way you're doing it, which is obviously necessary when conducting a systematic review. That's like the only two really big pieces of advice I would give.
Great, thanks so much. Any last call for questions? All right, if not, I think we'll go on to the next presentation. Great job, Maclaine, again. Thanks so much. Next is Daniela. Great. So Daniela Schrider, again, is a Hopkins undergraduate student. She did the area of interest in maternal, fetal, and perinatal health. And today she'll be talking about confidentiality in sexual and reproductive health care in Maryland. So close to home. Take it away, Daniela.
All right. Okay, so yes, today I will be discussing my essay titled State Level Actions to Protect Minor Confidentiality in Sexual and Reproductive Health Care in Maryland. So throughout this presentation, I'll have three main sections. First, I'll give a profile of Maryland, where I'll talk about sexual and reproductive health. And SRH is going to be the acronym I use for that term throughout my presentation, meaning sexual and reproductive health. And then next, I'll talk about the problem I address throughout my essay, which is breach and confidentiality. And I'll discuss adolescents' desire for confidential care and then the mechanism that confidentiality is being breached in Maryland. And lastly, I will discuss my policy analysis and my eventual policy proposal for the state of Maryland. And I'll discuss my review of state strategies for addressing confidentiality in insurance communications. So in general, Maryland has supportive minor consent laws and a supportive landscape for sexual and reproductive health care. The minor consent laws allow minors to consent for STI, prevention and treatment, contraception, sexual assault care services, pregnancy and pregnancy counseling, and all of this is paramount to facilitating adolescents' access to and utilization of SRH care. Maryland ranks number 7 in states regarding support for SRH and rights, but ranks moderately in adolescent SRH outcomes, which I'll discuss in a minute. And that photo there is Governor Wes Moore. Some of you may be familiar. And during his administration, he has been a champion of making progress in SRH access and rights for Marylanders. And then here I reviewed the landscape of SRH outcomes in adolescents in Maryland. So as for contraception in the top box, only half of sexually active teens report having used a condom at time of last sex. And this is important because condom is the primary way that STIs are prevented, and about only half. And then of sexually active adolescents, 74% did not use any modern contraceptive method at last sex. And modern contraceptive methods are the pill, any lasting reversible contraception methods such as the arm implant or the IUD, includes NuvaRing or a patch. And 16% did not use any method to prevent pregnancy at last sex. And these are all Youth Risk Behavior Survey 2023 results. In that bottom box, I discussed some Baltimore City rates. So Baltimore City experiences far higher rates of chlamydia, gonorrhea, and teen pregnancy compared to the rest of Maryland. That birth rate of 20.9 per 1,000 females aged 15 to 19 is almost double the state rate of 10.9. For chlamydia, 5,281 per 100,000 teens aged 15 to 19 is 5 times higher in Baltimore City than the next highest county in Maryland. And then for gonorrhea, 2,138 per 100,000 teens aged 15 to 19 is over 2 times higher than the next highest county in Maryland. Black 15 to 19-year-olds throughout Maryland experience much higher rates of STIs than their white and Hispanic counterparts. And Baltimore City is one of 2 Maryland counties or jurisdictions that is predominantly Black. So these differences might be seen here, might be a result of the structural racism that exists throughout the city today and is paralleled in the healthcare system, which makes access to quality care more difficult for Black people compared to white people. So next, I'd like to expand on the barrier I explored as a reason we may be seeing these adverse SRH outcomes for adolescents in Maryland, and that factor is confidentiality in care. In a review of perceived barriers to adolescent SRH services, confidentiality concerns were found to be the most important component of service-seeking behavior. And by confidentiality, I mean that they do not want their family or their peers to know about the services that they would be seeking. In adolescents who visited a family planning clinic, 36% reported that their parents were unaware of the visit. And this may be due to fear of parental backlash. I mean, a common source of anxiety for teens is discussing sex or sexuality or SRH care seeking with parents is revealing any information that could bring punishment or criticism. And the fear of what could happen, perhaps like verbal abuse or being kicked out, if their parents were to find out about their sexual behaviors or their sensitive SRH information is certainly a big deal. Among a sample of adolescent girls who were seeking services at Planned Parenthood, 59% said that they would delay or stop utilizing SRH services if their parents were notified. And this is a problem because we want adolescents to be empowered and to be able to seek care and to improve on their health. Also, I want to be clear that these confidentiality concerns will not deter adolescents from having sex. It will just influence their decision to seek the care that they need. And a strong piece of support for this notion is that one review found only 7% of sexually active adolescent females said that they would stop having sex if their parents were notified of their contraceptive service seeking. So, how is confidentiality being breached in Maryland right now? It's through a policy loophole. Right now, minors are dependent on parents' health insurance plan, meaning that the policyholder is typically perhaps a parent in the household, like mom or dad. And 55% of adolescents in Maryland are dependent on employer-sponsored private insurance. So this is a majority of adolescents in Maryland. These adolescents under private insurance are the primary population that my policy proposal will be applying to. But like I mentioned, minors can seek SRH services without their parents. And then when a health provider, such as their doctor, seeks the financial reimbursement from the insurance company for the services, right now the policyholder is being notified through an explanation of benefits document, also known as an EOB document, and that's being automatically sent to the policyholder right after services are being reimbursed. And for those covered by private insurance, by law, explanation of benefits and denial of claims are always sent. So basically, even if insurance were to cover all the services for the minor, perhaps like a STI test, an automatic document is being mailed to the policyholder, and that is explaining like the services, services by who, things like that, and other details that are being shared. So this issue has been identified before, and 15 states have varying policies to address this. The most popular is a confidentiality request form, requesting that communications from insurance companies be directed to a different address or different than that policy holder. Another strategy is to not send an explanation of benefits if there is no balance due. And then another strategy I found was to censor specific SRH services on the explanation of benefits by blocking out the specific list of what the services exactly were. Some of the cons and issues that I found with the implementations of these policies in different states is that it relies on the minor to be aware of the form, which is a little bit difficult for perhaps a 15 or 16-year-old to understand what the insurance landscape looks like. Most states do not specify if the law is intended or allowed for minors at all. It's unclear. And then the request forms may differ by insurer. So for a office to carry all of the different insurance request forms might cause some implementation issues. Censoring services, like that last strategy I identified there, still alerts that there was a health visit by a minor and likely who the care, like where it was. So it might clue into as to what services were being sought. And lastly, not all states legally require that the insurers even comply. They view it more as a request. I identified Washington's policy as the most supportive policy to address adolescents' confidentiality and seeking SRH care. This policy automatically blocks communication, such as the EOB, from insurance companies to the policyholders for specifically for SRH services that minors legally consented to. So in the health visits of these SRH services, a form, which is shown on the right here, allows the alternative information to be collected and filed, and the form is presented by the health provider or the staff member in the doctor's office automatically, and provides the opportunity for the minor to write where they would like the other alternative communications or the alternative address or email to be sent to. And then lastly, also this policy denotes that insurance companies must comply, which is helping with some of the implementation issues found in some of my other analysis. So therefore, I propose a new bill for a new policy for Maryland, incorporating elements of the policy from Washington that would allow Maryland to be a leading state in protecting adolescent SRH care, confidentiality, improving services overall. So essentially, this bill would include the automatic blocking of communications to policyholders regarding sexual and reproductive health services that minors legally consented to. The policy must have language to denote that it applies to minors, and the consenting minor must have the ability to redirect communications to an alternative address, email, or phone number, similar to how it is in Washington State right now. And this information would be collected through a form that is the health provider's duty to present at health visits for minors seeking the SRH care. And if the minor does not wish to redirect communication from insurers or for some reason the form wasn't filled out, then by default, communication should be sent to the patient's home address on file, but addressed to the patient rather than the policyholder, hopefully being caught by that patient before being presented to the policyholder. In general, a carefully crafted bill with these elements and an implementation strategy that improves on the shortcomings of the previous efforts will allow the policy to have lasting benefits for minors. Based on the recent steps Maryland has taken to protect access to SRH services in the state, I'm confident that the Maryland administration will see this as a policy that they will want to get behind. And to finish off my presentation, I'd like to say thank you to my reader, Annie Smith, for your guidance on this essay, and another thank you to Becky Shasha Bennett for helping me workshop this idea initially and introducing me to the policy side of public health. And lastly, to my parents and my grandmother for supporting me through grad school the past 2 years. Thank you.
Great job, Daniela. I learned so much from that presentation. I do have some questions, but I'll let others go first. Who has a question for Daniela? Emmy.
Great presentation, Daniela, and I will echo Sally and say that I learned quite a bit. I'm playing devil's advocate only because I support this idea. What about concerns about deductibles and other aspects of the insurance? If policyholders aren't being made aware of this, or et cetera, et cetera. So what is our response to that?
Surely that is certainly the most pertinent issue in implementation and getting this thing rolling. So, of course, services will always like list of services and costs and things like that will be listed on like an audit kind of form. So it would take us extra step to see what occurred. I mean, it's not like every day policyholders are reviewing every service that's being reviewed, but if needed, yes, it will be available because this is information that needs to be shared too, like a person who's paying for their services. I'm just saying that this prevents that first automatic explanation of what occurred. But yes, for like an audit or for a review at the end of year or anything, services will be listed for under an insurance policy plan.
Yeah.
And I'm not sure about the mechanisms of the details of what those services were. Like if it will say like, oh, sought by child on for STI services, things like that. I'm not sure on. But yeah, and basically it will be listed through like an audit or through like your online portal. I'm not so sure on the like how you access it, but it will be there.
Okay, thank you.
Yeah.
So great work. I want to do a shout out to our Title V partners who are, Becky's here today. So huge thanks to Becky and to Annie as well. But what I'm so intrigued by is that this issue hasn't risen to be front and center across many, many organizations in the US. And I don't know if from your read of sort of what happened in Washington, if the sense is that other organizations haven't prioritized this because it's politically divisive and it's not sort of central to the mission. But, I can think of lots of organizations for whom this would be central. So it just seems really surprising. I don't know if you have any thoughts on that.
Yeah, I haven't seen much because the Washington State one is kind of the leader and it's a little bit recent. So we haven't seen like outcome reviews or anything from that yet. But we do know in like the political climate that insurance companies can have a lot of influence over people. So they might be doing their best. I don't think the private insurance companies would be the biggest advocates for this policy. It would be other organizations. So I think that insurance companies might be working some magic to delay some of this dissemination and implementation and advocacy across the states.
Yes, David.
Thank you. Great presentation. I was curious as to what you think about linkages to Medicaid or into the state health department to be the payer of first recourse in terms of protecting these youngsters and also providing through the schools and other approaches that can wrap this around a non-private or insurer, basically.
So for Medicaid, Medicaid does have some extra protections. This applies for people who have dual Medicaid and private insurance, which actually it does exist that people have both. And so since Medicaid is a payer of last resort, this would still apply to them because they would be billing their private insurance first. I'm unclear because of some clauses of like exception, to what degree Medicaid sends explanation of benefits, or denial of claims. Denial of claims being that when all the services weren't covered, they'll send you a notice and your remaining balance. But Medicaid covers all like contraceptive. Maryland Medicaid covers nearly all SRH services for adolescents, so usually those communications aren't being sent back because it's been fully covered by Medicaid. or they're being limited in communications, which is good. Did that answer your question, or do you have any?
Well, I was thinking of some way to circumscribe the payer when it comes to sexual reproductive health issues, because no matter what you do, the potential uh, 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 response is to try to avoid contact with anything that would alert the family
Mhm.
for the reasons you so clearly outlined.
Yes, I agree that that is. I might not be understanding your question.
Uh,
I think is David, are you suggesting that Medicaid like automatically pay for
uh,
adolescent SRH?
yes, because the teenagers can go into the health department and receive services, and is there a way to then formalize or bureaucratize that approach so as to avoid any direct line between private or any other insurer that reaches the household?
Oh, yes, that could be an alternative pathway to explore.
Yes,
Yeah.
thank
Yeah.
you. Mhm.
Mhm.
Thank you very much.
Maybe I'll ask one last question, and that is, are you all trying to find a sponsor for this proposed legislation?
So I would have to talk back with, I used to intern at the Department of Health, which is where I had my advisor, Becky, who helped me workshop this idea. So now that I've wrapped it all up, I will consider my next steps. That would be the ideal. How amazing would that be? But, um, I have a lot more to learn about the bill process, so I'll learn that next with some help from my friends at the Department of Health.
Great, thanks so much. Excited to see where this goes. So thanks so much, Daniela.
Thank you
Great
very
job.
much.
All right, and we
Thank
have
you.
one more presentation today. Mackenzie Simon-Collins, like Daniela, is in the maternal, fetal, and perinatal health area of interest, and she will be talking to us today about human milk banks. So I will pass it over to you, Mackenzie.
All right, well, good afternoon and congratulations to my fellow presenters today. I am so excited to present my master's essay entitled Eligibility, Assessing Eligibility of Vegan and Vegetarian Diet Breast Milk in Human Milk Banks, Nutritional and Ethical Perspectives. This essay really combines topics that I'm truly passionate about. I've been plant-based for nearly 10 years myself, and I've always been curious about the health and social implications of these diets. I also got interested in breastfeeding in my undergraduate career when I started interning with a virtual lactation consultancy and pursued more research positions after that. So this essay really is a nice culmination of some topics that are very important to me personally. And when I learned that donating breast milk as a vegan is actually banned at some human milk banks, I felt incredibly compelled to discuss this issue some more. So here is the flow of my presentation today through background, objective, methods, results, and recommendations, some important abbreviations, and this is a legislation position paper. So moving on to objectives and methods. For the objective, synthesize existing breast milk composition evidence for plant-based diet adequacy, describe bank policies in Western countries, and to create recommendations for future human milk bank policies. For the methods, again, it's a legislation position paper. The process largely resembled crafting a review paper. And noticing that there wasn't a lot of data for our banks in North America, I created an original data set investigating their policies. So moving on to background. So in the research and social media spaces for breastfeeding and parents, you hear this phrase, breast milk is liquid gold, quite a bit. It refers to some of the simply amazing properties of breast milk. It's beneficial for all infants, supporting infant physical development, emotional, psychological, immunological, and etc. And it's really essential for medically fragile and premature infants. And it's recommended that NICU stock and feed donated breast milk. And donated breast milk does support fragile infants, but it's also an additional option for all infants during the formula shortage that we experienced a few years ago, as well as helping parents feel fulfilled by donating surplus milk and or bereaved parents. So I'm just going to give a very brief step-by-step on bank processing of breast milk. So the first step is screening the potential donors and receiving the breast milk. Screening policies are different for each bank. Some use questionnaires and or interviews. Some use biochemical testing like blood samples for nutrients and infections. There is, after receiving the milk, there's a pasteurization process, which includes different heat cycles and freezing the stored milk. Some banks pool samples between multiple donors. Most do individual samples. And the last step is distributing to NICUs and other infants. So the last important component of background this essay is the dietary patterns of plant-based diets. And I'm sure you've noticed discourse changing regarding plant-based diets, Eat Lancet, alternative proteins, all those sort of buzzwords. But the proportion of vegetarians, vegans, and flexitarians are increasing over time. And this increase is actually the greatest in young females, which coincidentally are also the people who would be lactating. I also wanted to point out that there are many religious plant-based eaters in addition to socially plant-based. And this shift towards these diets is recommended by Eat Lancet for Planetary and Food Security, as well as many other commissions as well. So moving on to results. A large component of my essay was synthesizing what is currently known about how plant-based diets influence breast milk composition. The current evidence is quite limited, but I do have some standout points pulled here. Study results disagree on whether breast milk from plant-based mothers is adequate without the need for a daily supplement. Several studies found some evidence of lower B12 in plant-based donor milk. One study found less iodine, one found higher selenium, but lower iodine and iron levels. And one study found higher DHA and saturated fat from omnivore mothers. But then on this slide, several more studies resulted in findings that disagreed with the points I previously raised. These disagreements can result from study design, sample size, populations included, level of rigor, and more research is truly needed in this space. But in general, most studies agree that plant-based donor breast milk is nutritionally adequate with a daily B12 supplement. One found that the prevalence of low B12 was not significant by dietary groups. So when you look at just the category of are they meeting adequacy, it was not significant. And several studies found no difference in vitamin concentrations between plant-based and omnivore mothers. And kind of adding to the difficulty of studying this space is that 90% of plant-based mothers already take a daily multivitamin. So most are reaching adequacy through their already normal vitamin taking. And the supplementing of these nutrients has been shown to increase serum levels, and that translates into the breast milk. And a further step of this is evidence for the impact of these composition differences on infant health is also very limited and remains heavily debated. So given the disagreement in the literature regarding breast milk compositional effects from plant-based diets, I believe it is important to also look at some of the cultural, social, and ethical issues at play here as well. This comes more apparent when looking at the policy difference between North America and Europe, but we'll get to that soon. So there are 1.5 billion vegetarians worldwide, and a subportion that doesn't eat meat out of necessity, and then the other subportions of religious and social vegans and vegetarians. There are documented patterns that omnivores hold negative representations towards plant-based eaters and more extremely towards vegans. And in the United States, there are different surveys and studies seeing trends of this in more conservative regions of the country. There are strong social biases in society towards this group, which could explain bias in potential donation policies. And then social media definitely has an impact on social perceptions of social minority groups. So considering what we know about composition and social attitudes, I now want to dive into organization positions and human milk banks. So most pediatric and nutritional organization policies on the international and national levels reflect an inclusive approach to plant-based mothers and donating breast milk. The European Milk Bank Association allows it with a B12 supplement. The Academy of Nutrition and Dietetics, as well as the AAP, advocate for plant-based diets and don't require any sort of supplementation. And then the last two on this slide also they have inclusive policies that allow donation with different levels of supplementation. But there definitely are exceptions. Here are two societies that do not allow any sort of vegan or vegetarian donation, even with any form of supplementation. It's fully not allowed. the German Nutrition Society, and the European Society for Pediatric Gastroenterology. So finally, let's take a look at what human milk banks are currently doing about this issue. On the left, I have the European human milk banks, and there was one study that did a survey of 118 milk banks across Western Europe. 40% always included vegan and vegetarian mothers, different percentages of supplementation, and then 27% always excluded, and that's even with any potential supplementation. And then on the right is North American human milk banks, so the US and Canada. And this is where I couldn't find any prior research at all. So I just took it upon myself to do some investigation myself. And I found 26 human milk banks and looked at their policies. And in the US, the trend was that they were a lot more open to plant-based diets donating. 76.9 allowed if they had adequate diets, 19.2% if they had different levels of supplementation, and only 3.8 fully excluded plant-based donors. So moving on to my recommendations here. So considering everything that I talked about today, the great need for donor breast milk for babies, and especially in the NICU, the increasing plant-based diets in young people, and what is currently known in the literature regarding breast milk composition, we recommend for exclusive policies barring plant-based women from donating breast milk to be removed. And we recommend to replace exclusive donation policies with more inclusive policies that screen for diet adequacy across all potential donors, and omnivore and plant-based, because people of different dietary statuses can have different nutritional deficiencies irregardless. And we recommend supplementation as needed for people with different eating habits. And just to close out, I'd like to acknowledge my reader, Dr. Susan Gross, and my advisor, Mary Catherine, and to all of my PFRH staff and colleagues. Thank you very much.
Thanks so much, Mackenzie. Great job. Again, learned a lot from all three of these presentations. What questions do people have for Mackenzie? I can get us started. And I'm sorry if I missed this, but what are the general rules for excluding donors? Are there other, what else excludes somebody from being eligible to donate?
Oh, beyond being plant-based?
Yeah.
Yeah, I mean, some of them are different prescriptions that parents take that might disqualify them. Recent infections, STIs, those are would be main disqualifiers.
David, do you have a question?
Did you call on me, Sally? Yes, well, I was thinking, a wonderful presentation. Is very important, I think, understudied. One thing I was thinking about, which I didn't see come up in your issues, was iron itself. And I was wondering how you think about that, because that it's a very high prevalence of iron deficiency in even pregnant women, irrespective of social class.
Yeah, and I would say in my investigation of the literature, I only found a couple of studies that directly compared iron in breast milk between plant-based mothers and omnivore mothers. There's definitely probably more out there looking at blood serum levels, but looking at breast milk levels specifically, there wasn't too much out there in the literature at the moment.
Can I go?
Yeah, go ahead.
Great job, Mackenzie. I know that you worked really hard on this. Can you describe your surprise or surprising things that you discovered during this journey?
Yeah, sure. I think just socially, I was very surprised by the difference between United States and Canadian milk bank policies and European, because at least for me, socially, I expected in Europe to have a bit more liberal policies, more inclusive policies. So it was very shocking that they had such a high exclusion rate in Europe. And when I looked at it deeper, it looked like that was more concentrated in Italy and Greece and other countries like that. And versus the UK had more policies that kind of resembled the United States and Canada.
Okay. Well, thanks so much. Any more questions? Last call for Mackenzie. All right. Well, if not, thanks so much to our three presenters today. You've really set the stage for more essay presentations to come. Like I said, I learned a lot. I'm sure everybody here did. So congratulations to you all. We're very excited to see next steps for all of these essays, in addition to seeing what you all do next in your careers. So thanks everybody for attending. Stay tuned for many more presentations later this spring toward the end of term 4.